How's everybody doing? Two things before I get going. Number one, preferred nomenclature is now persons with diabetes. Has anybody heard that? Instead of a diabetic. So you may hear me refer to that. You may also hear me fall back to diabetic because it's a hard thing to remember. So persons with diabetes, the other thing I wanted to ask is, what are people's experience in here working with patients with diabetes? A lot, little? Who feels comfortable working with patients with diabetes and giving recommendations? I would hope you would. Who else? But not unheard of. Can you raise your hands a little higher? I won't call on you. Okay, so the reason I ask is because I'm trying to paint, Heidi asked me to sort of paint with a very broad brush things that I would do over several sessions with a patient. So I'm going to cover a lot of different things, but 95% of my job is interactive. So please stop me if you have questions. And then you can also email me if things come up later. I'm happy to answer what I can. But to your point, the only experience I have with tuberculosis is when I was working in juvenile justice. And that was strictly treatment and testing. So you guys far exceed my knowledge there. Okay, so basically, you know a little bit about me. I work at OHSU. We are part of a pediatric and adult team. So we see all the way from birth to death. We're split out peds and adult. Within that, we have endocrinologists, physician assistants, nurses like myself, dietitians, all of whom are certified diabetes educators. And then we have social workers and PhD psychologists. The big thing is we serve all of Oregon, Southwest Washington. This 1,500 number that you see here, that's the total number, not the total number of visits. So obviously we see these patients multiple times over and over again, but that's how many we saw just as part of, and if you see this DS, MES, that's diabetes self-management, education, and support. Long acronym that just means we work with them and work with their diabetes. The one thing that I want you guys to know is we are the only endocrinology department in town that doesn't put a cap on our Medicare and Medicaid patients. So across the state, if you have someone, I mean, if they can travel, we will see them pretty much. It does mean that our waiting list is sometimes long. 6 months is not unusual, but they can also be referred specifically for education, not to see an endocrinologist. So what does that actually mean? That means that if you have what we consider an uncomplicated patient with diabetes, so type 2 but hasn't had a lot of formal education and would really benefit from education support and help managing their diabetes, that would be a really good candidate to be referred to just diabetes education. I can talk a little bit more about that, and if you have patients that you ever want to refer, you can always email me and I can give you more details on that piece. In our department, we are obviously our pediatric department sees predominantly type 1 diabetes, although we do have some type 2. And then in adults, we're more of a split. So we see about half and half type 1 and type 2, and some prediabetes as well. I mainly just put this up here because I like this, and I wanted to find a good excuse to put it in. But I would say this can you read this in the back? It says, Mr. Osborne, may I be excused, my brain is full. And why I put this in here is because this is sort of the antithesis of what we try to do. Diabetes education is really about personal education and really about customizing and tailoring what we give to the patient based on what they want and what they're ready to hear. So oftentimes what I start with is an assessment, right? And I'll talk a little bit more about that. So basically, whether we do group format visits and we also do individual appointments, but we cover these 9 processes. So the basic disease process, what is diabetes, what does it look like over time? Nutrition, as we'll talk a little bit about, is essentially dietary choices and food choices, physical activity, medications, monitoring blood glucose, and that has a lot of different forms, which I'll refer to a little bit later. Acute complications, so this is hypoglycemia, hyperglycemia, illness, how to manage illness when you're a person with diabetes. Preventing chronic complications, so this is what people tend to think about, feet, heart attack, those sorts of things, long-term repercussions of having diabetes. And personal strategies, this is probably, 75% of my job, I would say, is really not about education about medication, but really how do you fit your life into diabetes, right? Or how do you fit diabetes into your life? And then obviously that also ties in with developing personal strategies about behavior change. So we did a lot with motivational interviewing. Anybody familiar with that? Who feels comfortable using that? I would say I'm kind of a half hand as well. So it's the sort of accepted mechanism for change talk in diabetes education. I think there's some debate as to how effective it is, but I won't go into that since that's definitely not my area of expertise. So the big thing that I hope you hear throughout what we're talking about today is diabetes is lifelong. Although there is some debate about diabetes in remission these days, we still consider it a lifelong condition. There's no one and done. So I never see a patient and think, you're all caught up. Your education is done. You know everything about diabetes. So I would expect that of you guys as well, right? You are a touch point like any other healthcare professional. One of the things that I was telling Heide before I started speaking is less than 4% of people with diabetes get formal education. So if you think about that, that doesn't mean they don't get informal education from neighbors, aunts, uncles, some format of some healthcare provider, but as far as documented, tracked education, less than 4% nationally. So it's a very small amount, and there's a lot of opportunity there. So the big thing that this is saying, this is kind of a busy slide, but really what I'm saying is the support is really important. The education is only sustainable if we have support that goes along with that, right? And so where do we generally fit in? Obviously, when a patient is first diagnosed, we'd like to see them annually, if possible, just to brush up on what's going on. If things change, so a new diagnosis perhaps, is another touch point that we might want to see them. And then when things in their life change. So maybe now they're divorced and living a very different lifestyle, or they have kids at certain times and that makes management difficult. Those are the kind of things that I tend to work through with patients. So hopefully by seeing us, and also something that you guys can work through, by giving more education and really working on the support system, we hope to aim for better quality of life, increased better lifestyle behaviors, obviously what they're doing actually having more effect on the outcomes of their diabetes, empowering them to take control of their own condition, healthy coping, and then what we really hope for is that obviously it brings down A1C, we reduce complications, distress, depression, hospital admits, and ultimately healthcare cost. So another kind of busy slide, this is what we would call our education cycle. This is all required by the American Diabetes Association. I'm not going to go into too much depth on this, but basically we always start with an assessment, as I would think most healthcare providers would, right? And we really determine a plan with the patient. I just want to underline here that this is really about the patient, right? So what I think they need does not really matter if they don't think that they need it. And so a big part of what I do is figure out what they actually feel like they need right now. So to give you sort of an example of that, I'll spend an hour with a patient talking about managing hypoglycemia or taking their insulin or something like that. And then when we get to the end of the visit, I'll say something like, well, we've talked about a lot about your diabetes. What do you think you want to work on going forward? And they'll say, out of the blue, checking my feet more often. So why I bring that up is because what you may talk to a patient about, what they even may bring up, may not be what's really present in their mind as far as what they want to work on. So that's really where this comes in, is this is really, should be guided by the patient and not by us. I think, depending on the group that I'm talking to, but I see this a lot with nurses, we tend to force feed people information. I'm not putting that on any of you because I'm sure none of you do that, but I tend to see that, that we really have things that we feel like we want to teach a patient, so we kind of cram information into them, ask them to regurgitate it to us, and then expect that they took that in, right? And so really what we find more effective and what the literature supports is that by them setting their own goals and by them really setting the tone of the visit, they're going to take in a lot more. If you think about the average adult has an attention span of anywhere from 5 to 15 minutes. When you go beyond that, even like this talk right now, how much are people really taking in? So we really want to come back to that main thing and ask them what they want to work on going forward and see how we've touched that. So we start with that plan. We'll do some sort of education intervention based on what they're interested in, set some outcomes. They actually pick a goal, then we're going to follow up with them, whether that's by phone, in person, some format like that, and then we'll communicate that to the rest of the team. We'll measure sort of how well they're doing based on their own goals that they've set, And they'll either leave that and come back to us at some point, or they just continue right back along this. So I would say that even though it may not be formal, this sort of pattern is very easily something that you guys could work with with a patient that you're taking care of that has diabetes. Do you have a question? Okay. So this is just an example of how we help a patient choose a goal. So based on basically some of those content areas that I showed you before, we would have these just as ideas and have them set a goal, how often they want to do it. So this is just SMART goals, right? That they're simple, measurable, repeatable, and then we'll see how confident they are, and then this is really about barriers. So this just gets back to what we can do to help them address some of that. And then this is just another example of the support system. So oftentimes we'll say something like, well, who supports you in taking care of X disease? And the patient says, I have no idea, right? Or no one. So these are both ideas to look for support and things they may already be doing that they may not consider as support, but that we just offer as examples. So this says, before all I could think about was food. On this fitness plan, they've turned my thinking completely around. Now all I think about is doof. And that's really what we're doing, right? We're really just adjusting perception most of the time. Most of the time when I see someone who has diabetes and we start talking about what they're eating, they think I'm going to tell them to cut out anything that they like, to never eat it again, to stop drinking, and basically to have no fun in their life, which is actually the last thing that I'm going to do, right? There is no food that I would tell a person with diabetes not to eat. And I'll talk a little bit more about that. So I'm going to shift gears a little bit. Are there any questions before I move on? I really wanted to give you guys an overview of what I do before we talk specific diabetes stuff. And if I'm oversimplifying or over complexifying, let me know and we can sort of stop, okay? Because I don't want to be insulting, but I also want to make sure I'm covering things thoroughly. So when we talk through meal planning and what people would typically term diet, we don't really talk about diet, right? So we really talk about meal planning and food choice. Diet has a connotation. What do people think when they hear diet in here?
Deprivation.
Deprivation, right? What else? I heard bad up here by Heidi.
Some foods are off limits.
Yeah, some foods are off limits. I think of Oprah, because if you've ever seen Oprah magazine and she tends to expand and contract on the cover of that, that's really a result of diet, right? We do something that works for a while to an intended goal, but then we can't sustain it. We quit it and we go right back to what we were doing before. So we really sort of preach a different idea, which is that there is no one-size-fits-all diet, right? Any diet, and that's part of why American Diabetes Association doesn't really endorse one specific diet, is because number one, the evidence doesn't support it. Number two, people have a really hard time sticking to this. So taking pieces of lots of different quote-unquote diets to make up a meal plan is really what we're aiming for based on a lot of characteristics. What can the patient afford? What is the patient willing to do? I could tell someone or help them see that they can buy healthy things at a farmer's market, for example. But if going to a farmer's market is never going to be part of their reality, why would I propose that, right? It's not a possibility. So really what we talk about is about consistency, and we aim for these three things: balance, moderation, and variety. If they're keeping those ideas, so we have to define that obviously, right? But if we're thinking about balance, moderation, and variety in a diet or meal plan, that's really all we're asking for. So healthy choices will incorporate this plate method, but really what we want is a mix of carbohydrates, small amount of healthy fat, and protein. Okay, and we'll talk a little bit about that in a second. So I talked about the plate method. Who knows what the plate method is? I see a couple hands. Anybody want to share their definition of it before I show that?
So half for veggies, and then 1/4 protein, 1/4 carb.
Mm-hmm. And how would you tell someone to build that plate, do you think?
Start with the veggies.
Yeah, why would you do that?
Because most of us don't eat enough.
So most of us don't eat enough, right? Also, so let's just skip to that. If you look at this plate, right? If I started with the carbs here, what do you think I'm going to do with that quarter of the plate? That quarter of the plate is going to look like that, right? So really what we're thinking about is we're saying eat all those foods, just start with a different organization of it, right? So you could put half of your plate as veggies, right? They're still probably going to cut it like that, but we suggest starting half of the plate putting some sort of protein source. Does it have to be meat, do you guys think? What are other good sources of protein? Beans, tofu, yep. And then trying to leave as little space as possible for this, right? The reason we say this is that obviously this is the big carrier of the carb source, calories, and is going to increase their blood sugar the most. Questions about that idea? Okay. So this is a little bit more on the plate method. These are recommendations that we have. One of the things that's important for patients is if you're going to ask them to be separating out by macronutrients, they need to know what macronutrients are, right? Do you guys, who here feels comfortable with these three and could define them for a patient? Raise your hand if you feel comfortable with that. We're not dietitians in here, right? I would say giving yourself a general understanding of these three would help a lot with patients, right? If you're going to really talk about meal planning, which is what I'm suggesting, you need to have a basic understanding of where the carbohydrates are coming from, right? Where protein is coming from and where fat is coming from. Who thinks that we should be prescribing a low-fat diet? Anybody? So research is changing on this consistently. We're finding more and more that healthy choice fats, vegetable oils, liquids and soft margarine, nuts and avocados are actually more beneficial with blood sugar control. So the data is not conclusive at this point, but I would say we're moving towards a much higher fat, lower carb. So we tend to see things like ketogenic diet. Who's heard of that? Not something that we're currently prescribing for patients with diabetes. Does anybody know why that is? Any guesses? Yeah.
So I've heard a lot about celebrities doing the keto diet because it loosens the gut and all of that stuff. And so is that really beneficial for diabetics though? People with diabetes?
So the two things that I would say is, number one, a ketogenic diet, what it does do is you're taking in a very small amount of carbohydrate, right? So uniformly it makes managing diabetes easier, right? What it tends to do is carb restrict though, and we need carbohydrates. We need carbohydrates to survive. Primary fuel source in our brain is, anybody know? Glucose, where do we get a lot of our glucose from? Carbohydrates. So the bottom line is those diets are more difficult to manage, and I don't really want to give you a yes or no answer, to be honest, because the data really is not conclusive on that. What I will say is they tend to be more dangerous for patients with diabetes, particularly with type 1. So it's a sort of yes or no answer, but I'm just going to leave it at that. And then the other thing that we do is we tend to give recommendations as far as servings. So if you see here, where I would look at is most of our patients are fitting in these two, right? 2 to 3 servings to lose weight for women, 3 to 4 servings, and this is counted by grams. If a patient isn't counting carbs, is this going to be very useful? Probably not, right? So what we want to think about is, we need to know what is an average serving of carbs, and then we need to translate that for a patient to say, what this means for you based on what you're eating is this many servings of X and this many servings of Y. Does that make sense? All right, so moving on to physical activity. This says, if you haven't exercised in a while, you may need to stretch and warm up before you stretch and warm up. This really refers to the fact that what patients tend to hear is recommendations and guidelines, right? Does anybody know ADA recommendations for exercise when you have type 2 diabetes? I'm looking at your direction.
I don't know if I can spell it.
That's okay. 5 days a week, 30 minutes of exercise, right? Or some combination of that. They're actually encouraging now to break that up, even into like 15-minute segments. Does anybody know why that is? We're trying to get people off their butt, right? So if everybody wants to stand up for just a minute while we're talking about physical activity, please feel free. I won't ask you to do any stretches or anything. Just get off your butts for just a second. The reason I bring this up, though, is we really want to think about making this also custom to a patient, right? So although the recommendation is 5 days a week for 30 minutes a day, are you going to take someone who's morbidly obese, hasn't exercised in 20 years, and say, get out there and walk or run or swim for 30 minutes 5 days a week? What is the success rate of that, do you think? I would say as close to nil as possible, right? You don't need to stand up any longer than you want. I just wanted to get you guys out. What we do think about is frequent, and you can see this acronym is FIT, frequency, intensity, type, and time. This is really more for the patient just to call out what they're going to do, right? So I may start with the patient and say, what do you think is an achievable goal for you? Can you walk for 5 minutes? And if they can walk for 5 minutes, I may say, is it reasonable to start with 5 minutes a day? Or maybe not even that much. Can you walk 5 minutes in 1 week between now and the next time we talk to you? That may be a reasonable goal, right? So me starting right out with this idea of, I want you to walk every day for 30 minutes in the next week. It's not going to be successful, so why would I even start with that? I would encourage you to ask your patients what they think they can actually do. They may spout out exactly what you want to hear, right? Which is once you give them this recommendation, they're going to say, well, I'm going to walk 5 days a week, and I'm going to swim and ride my bike to work, and I'm going to do all this stuff. How likely is that? In my experience, not supremely likely. If they want to set those goals, I'm not going to discourage them, but I want them to set those goals, right? Questions? So, this is still what I think most patients think we're going to do when we start them on insulin. Right? Has anybody started a patient on insulin before? Like actually walked them through their first injection? What's that feel like? Or maybe it was great. What was your take from that?
Well, I think people are always anxious.
Mm-hmm. What do you think they're anxious about?
Yeah, they didn't like the thought of giving themselves a shot.
So first of all, self-preservation tells us do not stab yourself with a needle, right? That's a weird thing. So if you've ever, who here has taught someone how to test their blood sugar with a blood sugar meter?
Yeah.
What's that experience like? Have you ever noticed that someone tends to put that lancet up to them and then pull it away as they're injecting? That's a basic physiologic response, right? I don't want to hurt myself. So by doing this, you're violating like basic things about protecting yourself. So we're asking someone to willingly do this once to several times a day, right? So the first thing is just to understand that this is scary, and they may miss a few injections especially to start with, right? But that's one thing that I try and remind myself of because it becomes every day to us, right? I'm sure things with TB, every day. You have cough, you have a fever, all these things that you guys are used to assessing. That's new for that patient every time. I try to remind myself of this because for me, seeing a needle, seeing a lancet, starting someone on a pump is not a big deal. But for them, this is a life-changing event, right? So, who here would feel comfortable starting someone on insulin? Or talking to them about how they're doing it right now? Not too many? So we're going to go through that. So I wouldn't expect it, but I just wanted to ask to make sure that we'll see where we stand. So a couple of things to think about, and you maybe remember this from nursing school or working in the hospital or working with other needles. Lots of different sizes, right? We have the smallest we generally use is about 1/3 of a cc, so 30 units is the smallest insulin syringe we'll use as far as volume, all the way up to 100 units. The one thing that I want to draw your attention to is the size of needles, right? So does anybody think there's a reason to use a larger needle other than to torture a patient? Why would we use a longer needle, and why wouldn't we put everybody on a 4 millimeter needle?
Get into the sub-Q back.
So interestingly, they've done a lot of studies about how thick people's skin is, and there's pretty good data to support that the thickest, so skin doesn't actually vary that much. Subcutaneous fat varies a lot, but we tend to see the actual thickness of that dermal layer not more than about 3 millimeters. So for that reason, there is actually no good reason to use a needle longer than 4 millimeters. It looks scary, it may hurt more, they may be less likely to use it. So the first thing I would suggest to you guys when you're thinking about insulin is just, and especially someone who's having a hard time injecting, what size needles are they using, right? That's just an easy thing. This example down here is just of an insulin pen. In my experience, I find that nurses are the most uncomfortable with this because they didn't see them in nursing school. How many people have dealt with an insulin pen before? So quite a few. So to that end, anything that you guys can think about as far as what's different between an insulin pen and an insulin syringe? Just shout them out.
Drawing it up versus already just being.
So it's already drawn up, right? So that's a convenience factor, right? What else?
Maybe safety.
Safety, how so?
You're only disposing of the needle.
So you're only disposing of the needle, yeah. You could argue that they both have a needle, and you could get very similar in sizes of those needles. What else? Has to do a little bit with the pre-drawn versus the not pre-drawn. So when you're using a pen needle, right, you're changing out, the recommendation is to change out that needle between each use. Do we think that patients do that? So we're going to continue to recommend that. Does anybody know why?
They get metal slivers.
So if you use it over and over again, there is some potential of dulling that needle. So when we think about scar tissue developing from many injections, we're increasing the risk of that. What else? Infection, certainly, right? As you're sticking it into a non-clean surface and then pulling it out and sticking it back in. That's another good one. What else? The other one is accuracy of dose, right? So, and this goes back to when someone first puts a needle on, you really want to teach them to prime that needle. Does everybody know how you do that with a pen needle? So you'd really turn the back of that, depress the plunger. So that's, I know it's kind of hard to see down here. It's right there. So you're going to turn this little dial to 2 units, press that plunger, and you should see insulin come out. That doesn't always happen, particularly with a new pen. So you're going to actually instruct them to keep turning that and pushing that 2 units until they see something come out. Right? One of the things that can happen when you leave that needle on, especially if they're traveling, is that insulin will expand and contract, meaning that they'll lose some insulin or it'll suck back into that syringe. They're not getting an accurate dose. Not as much of a problem with type 2 diabetes because a unit here or a unit there does not make a huge bit of difference, but it is something to think about in terms of accuracy. What about storage of insulin in general? What do you guys know about that? Refrigerate when and how? Always? So this is a big thing as far as patients actually using their insulin. They think, oh, I have to leave it in the fridge, so if I'm out, I'm not going to take it. Is that true?
No,
So what insulin needs to be in the fridge?
or when you receive it, so new, so.
Unopened insulin is good until the expiration date. Once you open insulin, whether you put it back in the fridge or not, how long is it good for?
30 days?
28 days, yeah, so 28 days, and that's as long as it doesn't get above 86 degrees, okay? So let me just repeat this. They do not need to refrigerate their insulin, okay? So once you start using an insulin, it doesn't make it last longer, and in fact, cold insulin is more painful to inject than room temperature insulin, okay? So we would encourage people to bring it with them. There are sleeves, they're like for the best example I can think of is they look like a beer cozy. If anybody knows what those are, that wraps around a can. And you essentially just get that wet. And you could use tap water, and it will keep your insulin cool for up to 24 hours. So for people traveling, someone living on the street, that is an option, and they're very, very cheap. So if you can get some way, if they can borrow some money, if you have access to resources for them, that's about an $8 purchase that can keep their insulin good. So, unopened insulin, like I said, storing in your refrigerator, 36 to 46 degrees, good until expiration date. Opened, 59 to 86 degrees. It's helpful to mark the date. If they can ever get to a place where they're just opening a new one at the beginning of the month, that helps. A lot of patients, especially type 2, are going through more than a vial a month anyway, so they're going to use it up, so they never need to refrigerate it once they open it. Does that make sense? And then we won't talk about insulin cartridges, but same thing. You still are, yeah, go ahead.
If the person is used to refrigerating after it's open and that they know that it's always there, is it okay?
The only thing that I would say is that it may be more painful that way, so you can always just ask about that. But there's no real reason to not refrigerate it. I think this is about establishing a behavioral pattern. So if they have a pattern that works, the last thing I want to do is be like, throw that out and do something because I said it, right? Especially if there's not good research to support that. So this is just what I was talking about. There's these travel coolers. There's also the ones that I was talking about that look like a little sleeve. That's made by a company called Frio, is one that I know of, F-R-I-O, if you're curious about that. And then there are some aids This is a MagnaGlide. Has anybody seen one of those? It goes over the outside of a syringe, and it actually is like a magnifying glass so they can see the number of units if they have vision problems. How am I doing on time? Okay, so should we cover all these? You guys are all healthcare people. Let me quiz you on all the different action times. So I only put all these on here because I want you to remember that that's what this feels like when you show them one insulin, right? What 8 looks like to you is what 1 is going to feel like to them. What I pull out of that is I'm going to take the insulin or insulins that they're taking, and I'm going to break these things down for them. Why is that important? If you were about to take these insulins, why would you want to know this?
So you know what to give it to yourself.
You're exactly right. How does knowing this know? So what these are action profiles, right? You guys remember these from school? So it used to be that we really only had, well, when I was in school, it was R and N, right? That's about all we had, right? So, and what we really learned is you drop the R and then you drop the N, right? That's about all that I remember. So when I started working in diabetes, that's what I remembered, right? Now we have all of these, and there's a whole bunch more even on the market since we've made this. But the bottom line is, R and N are available over the counter. Does everybody know that? No prescription. Walmart, $25 a vial for each one. So any patient that I talk to that I think may be in a financial pinch at some point, I will always mention that to them, because that's something that they don't need to be seeing an endocrinologist or even a primary care provider, and they can get a life-sustaining medication. I still think that's too expensive personally, but given that most of our insulins used to all cost that, it's the one benefit that they still have. So one of the things they may need to think about then is talking to their PCP, their endocrinologist, about what would my dose be if I were to go on those medications. So that's a really good thing for you guys to sort of interject and say, this is a possibility for you. You need to talk to your primary care doc about what the dose would look like. Questions about that? Yeah.
So let's say for someone who doesn't speak English, or like really has a hard time with health literacy,
Mm-hmm.
what is the simplest way to just keep them out of trouble?
In terms of insulin?
Yeah.
So the two things that I would say, number one is separating their insulins. So literally putting their long-acting insulin in one place and their short-acting in another, because one of the things we see the most is switching the two accidentally. So that's one thing that I would say. And then the secondary thing is what we tend to see is, is anybody here familiar with insulin to carb ratios or correction factors that people use to determine insulin doses? Oftentimes we stay as far away from that as possible. So giving them concrete doses of both of those medications and having them write them down is probably the most simple way. But honestly, establishing a relationship is probably the most important thing to keep someone safe. If they feel like they can call and ask with a question, I feel so much safer starting someone on insulin like that than someone who may have really high literacy, but is just going to do whatever they want to do. Does that make sense?
Yeah. Some people get away with only long-acting.
It totally depends. So that's more a question of blood sugar, right? So we would use their actual blood sugars to determine that. Again, I would say it's a matter of safety. If you're that concerned that they can't manage those two, then it's probably better for them to have a little bit higher blood sugars than for them to be constantly yo-yoing and putting themselves at high risk of hypoglycemia, right? Yeah. Okay, so all of that to say, I'm always going to summarize with the things that I'd like you to take away, right? Shortest needle, priming if you're using a pen needle versus a syringe. Don't refrigerate after opening, not necessary. Don't change it if it's working for them. And one thing I didn't cover was pinch versus no pinch. Does anybody know what that's referring to? New data out there. When you give an injection, do you need a pinch when you give it? So we used to always tell people you had to pinch, and then there was sort of, you can if you want to, whatever you want. Now the recommendation is actually you don't need to pinch at all. So people can still do it if it makes them feel comfortable, because some people just feel weird, particularly if they're thin, injecting like that. But if you think about it, if you're using a 4 or 5 millimeter needle, the likelihood of you going into your muscle is almost nil regardless of how thin you are, just because of the thickness of our skin. And then obviously discard after 28 days. So I left some time for questions, but also technology seems to be the thing that people want to talk to me about the most. Before I cover this, who's familiar with the technology that exists out there for diabetes in general? So continuous glucose monitors, insulin pumps. Who's seen one or had a patient with one? A few people. So I want to spend more time on continuous glucose monitors because it's something that you could get for your patients. But just to give a brief idea, essentially an insulin pump is a reservoir of short-acting insulin that's housed within the pump that the patient is connected to either by tubing or by an electronic signal that's talking to the pod that's delivering that insulin, and they are getting rid of their base insulin. So that basal, Lantus, Levemir, Tresiba, whatever long-acting insulin that they're on, they're getting rid of that, and now all of their insulin is coming through there in short-acting insulin. So we give a small dose every hour over 24 hours, which counts as their basal insulin, and then they still are giving a bolus, which they would typically do with an injection of Humalog or Novolog, the same way that they would any other time. They change these sets out every 2 to 3 days and relocate them around their body, and there's all kinds of pretty amazing stuff happening with insulin pumps in terms of them working with a continuous glucose monitor to control delivery. The one thing that I would add, just for you guys to convey to patients, is that this does not relieve them of responsibility of taking care of their diabetes, right? There's actually, you could argue, more involved in being on an insulin pump than doing injections. The literature also supports that a pump alone does not have any more than about a 0.1 to 0.2% effect overall on A1C. Pump and sensor is a little bit different. It's more like 1 to 2% when they're talking to each other. But a lot of people, I think, even type 2 diabetic patients with type 2 diabetes, think that that's going to sort of solve all of that for them, and that tends to not be the case. So CGM, who knows what a continuous glucose monitor is? Go ahead. What do you think?
It monitors your glucose continuously, right?
Yep. So it's in interstitial space, right? They insert some sort of reading device under their skin, and that sends a signal to some sort of device that's going to display the results for them. The really amazing thing about it is a true continuous glucose monitor is 24 hours a day. What would you say is a lot of finger pokes for a patient? If you see a patient, you're like, man, they're testing a lot. How many would that be?
Depends on what they would say about it, but I would say even 4 is, a lot.
That's kind of at the high end, right? Even for a patient with type 1 diabetes, I would say someone who's testing 4 to 6 times is testing a lot, right? Have you ever seen someone with type 1 diabetes and looked at their fingers? They're destroyed, right? I mean, quite honestly, even though that's improved, their fingers are just calloused and they tend to only do one hand. So rotating hands can help with that. But if you think about, let's say 5 times a day, just for the sake of argument, that's 35 tests in a week, right? Wearing a sensor that's monitoring them every 5 minutes, that's over 2,000 tests in that same week. With them, at the point that we're at now, testing 0 times. There's no calibrations even needed, meaning testing their blood sugar and talking to the continuous glucose monitor to make that number accurate. So why I bring this up is because many patients with type 2 diabetes will qualify for this, even Medicare and Medicaid patients. So this is something that you guys may not be assisting them with getting, but bringing that idea up to them is definitely a possibility.
And they love it. Like when they can read it on their phones, they're
Yeah.
invested and they're like,
Yep.
oh, look. So you can really see a change in how they get invested in it.
And to be honest, we have to do a little bit of front-loaded work so that they have an understanding of how to read that data. Because for most people, they're used to seeing a trend where it's like a point here, a point here, a point there. And so our brains want to connect those points and say, oh, my blood sugar went right from here down to that line and then up somewhere else, right? What a continuous glucose monitor does, and you can see on here, these guys right here are the lines. Each dot on there is a blood sugar, right? And so they're actually connecting the dots literally, right? And so that's pretty amazing, and most people have not had that kind of information. So what do you think they tend to do with it? Dramatically overreact, right? So now, typically they would check their blood sugar and then they wouldn't check it again for 4 hours. Now they check it and they see that 2 hours after they've eaten, they've gone up 150 points. What do you think they want to do in that situation? give themselves more insulin. What does that set them up for? Stacking and a precipitous drop, right? So it's amazing as a trending device. We have to be really careful as far as a treatment device because people want to be more involved and more engaged in their treatment, which we want, but we have to be really careful about how they make those decisions. So I brought up two just because they're well covered by insurance. So the Dexcom, that's this one right here. You see it's a whole series of devices. This is the receiver that comes with it. This is, you can follow it on your phone, which you can then also follow it on an Apple Watch. But the bottom line is that I want you guys to know about this thing. This is the G6, which has just come out. This is a 10-day wear, 0 calibration, very easy to insert device. So they would only change this 3 times a month, and they would have all that data. If they're following it on their phone, they also have the ability to share that data with their provider, so they can see it in real time, and also with a loved one or someone else to set up some sort of emergency readiness stuff, even to the point of it will send that person a text message and say, X person has just had a low blood sugar, right? And then they can set up a communication to call them or call 911 or whatever they need to do. So that is a true continuous glucose monitor. The Libre, which is this one over here, is something that's come out in the last 6 months. This is really the device that I tend to think about for patients with type 2 diabetes because they don't need all of the warnings and bells and whistles that come with this. This is essentially this little button that goes on the arm, very easy to insert, no calibrations, 10-day wear, and anytime they want to know their blood sugar, up to 8 hours past from when they last checked it, they're going to get all of that data by a scan with a glucose meter. So they just scan over that thing, and then it's going to give them all that data. So really useful for people who have a hard time poking their fingers, but they can still get that same amount of data. What you miss with it is, with this one, when you hit a number like 80, it's going to beep at you. And you can even set a high number, so if you hit 250 or something, it can beep at you. None of that's going to happen with this one, but for a lot of patients, they don't want that information anyway, right? They're not going to test it, they wouldn't know what to do with it. It's overwhelming. But this gives them a ton of data still, and it eliminates finger pokes. So the biggest thing with this is they have to be an MDI patient, meaning multiple dose. So they have to be basal bolus therapy. This is not your Lantus patient only. This would be a patient who's taking several doses, and they have to, to get on the thing, they have to be testing 4 times a day. So this can be tricky, right? It's 30 days of 4 times a day, but it's sort of that carrot to say, if you can get to that point, then you can wear this and finger pokes can go away. Questions about that? Yeah.
For the monitors, how do they work? Where are they put them?
You mean as far as this guy?
Yeah, both of them.
So they would just carry them with them.
No, but the needle, how do they inject the blood?
Oh, so this one, right, see where that little hole is right there? There's a little piece that they insert into themselves. It comes with an inserter. They put it on their arm and basically push down, and it inserts it in for them. And then
So
they
it goes
pull.
on the arm.
Yep, that goes on the arm. The Dexcom is approved for the abdomen, but patients wear it a lot of different places. And the same exact process. This thing right here is the inserter. And so they pull off this little orange piece right here, push the button on it, and it inserts for them. They pull that away, and they've got basically the plastic housing and a piece of tape that
So
keeps it on.
it's like a little sticker with a
It
little
is.
needle in it.
Yep. And it doesn't even have a needle. It's a flexible cannula.
Uh,
I would say it hurts less than an insulin injection, and most people don't feel it. It's always the person you tell it won't hurt that will feel it. So I just don't tell them that. I say it should be relatively painless, and I try to be as honest as I can with that kind of thing, because that tends to come back and bite you when you make false promises. Other questions? So I have about 12 minutes. That's about all I have, but I'm more than welcome to sort of talk through scenarios. I didn't know what would be helpful for you guys, so I'm trying to paint with a very broad brush, but I'm also very willing to sort of talk through some scenarios. Yeah.
Okay, here's a scenario.
Okay.
What do you say to someone whose diet consists of ramen noodles and fast food, and they have horribly out of control blood sugars?
So the question is, what do you say to someone who ramen and fast food is all they eat and horribly out of control blood sugars? So one of the things first that I would say, just in terms of your own thinking process, is to try and take some of the value-based stuff out of it, right? Because we tend to think about good control, good diabetic, all of those things, which when we're putting that on someone, we're automatically putting them on the defense, right? So the first thing that I personally do is try and get rid of all of that. It's just what is, right? So what their blood sugars are, what they're eating, that's what is right now. I would say the biggest thing that I work on personally is this is small steps, right? Instead of really trying to, so the first thing I might do, to be honest with you, is look at that fast food menu with them and say, if you're going to eat fast food, what are some options there that are still affordable for you that you might be able to eat? And they may say, oh, I'm not going to eat anything but Whoppers and fries and whatever. So we may start working initially with maybe just one of those meals a week is something like that to find something that they like. So I would start with a small place like that. With the ramen noodles, I might actually think, what could we add to the ramen noodles to make it more nutritious? Because what I'm really getting at is they may eat that ramen, but do you think that's going to be very filling? So they're going to eat that ramen, and then I'm more worried about what they're going to eat after that. So I'd ask about some things like that. So really thinking around just getting them to avoid something, and if we can build in any place things that are more supportive of diabetes management, eventually where we're trying to move to is just substitution, right? And then if they want to eat that because they like it, what can they add to it that makes them more full, that has more nutritious value, and that's actually going to lead to better control. That makes sense? Yeah. Other questions? Scenarios? Concerns? Yeah.
Quick, I have a lot of patients that I think their big hang up is when they think about insulin, they think, oh, this is end-stage diabetes, this is horrible diabetes.
Mhm.
I know somebody who lost their foot. So reframing that I try to tell patients, hey, you can get off a lot of oral medications. This gives you a lot more flexibility with your diet, as long as you know how to adjust. So I'm curious how you approach that conversation. And
So one thing is sort of changing the perspective, like you said. That used to be true, in all honesty, right? It used to be that we really move people to insulin as a last-ditch effort, right? So really part of it is just changing the understanding to say the control is really what we're looking at, right? How we get there is how we're going to work with you, right? And so I think you bring up a really good point that you're actually taking some things away. I also think, you want to be truthful with them, and so I will never tell someone that you're definitely going to get off it if you do X, Y, and Z. But I will have a conversation really honestly and say, generally what we can do is we can start you on insulin now, and as we work on some of your lifestyle decisions, as those things change, we may be able to do some different things with the insulin. The bottom line point that I would make to them is at the point that they're in where you are starting them on insulin, there really isn't another good choice, right? We've sort of exhausted those opportunities. One thing that I would caution you to think about is, can I actually start them on insulin sooner, right? So for someone whose blood sugar is dramatically out of control, we should be thinking about starting insulin long before we mostly do. We see patients that A1C has been 10, 12 for 5, 10 years, and the provider keeps saying, oh, work on your exercise and we'll start it next time. And that never happens, right? So being realistic with them and saying, hey, if those things happen, we can back off of these things most of the time. But I think the honesty is the piece of it, and explaining what your thought process is, rather than figuring out a way to trick them, essentially, which I think we often do. It's like we have to manipulate them into seeing it from our perspective, rather than saying, this is always your choice, right? I'm giving you this based on scientific information and what I think is going to be the most helpful, but if you don't feel comfortable doing this, maybe the first thing they need to do is actually see an educator or a nurse that can walk them through saline injections, right? Say, well, let's see what it feels like. I would say roughly 75% of patients that I see to start on insulin, when they walk out, are so surprised at what they're doing compared to what they thought it was going to be, right? The reason I showed the picture of that giant syringe is I think people really think that they're going to be like harpooning themselves, right? And that doesn't make it any easier, but I think going through the process, I'll often do it myself, and say, how about I do one and you do one? Those kinds of things make it a little bit more, and also just being honest and saying, this sucks. There's no two ways about this. This is a difficult thing that I want to help you through. I think it's best for your management now, and we can move from there. Yeah.
I currently have an extraordinarily challenging TB patient that is deaf, mute, illiterate. Her first language is Korean Sign Language. She's a type 2 diabetic, and she's refusing to check her glucose. And she has TB, so she's not eating, and she is not currently on any medication for diabetes. And INH also affects blood sugars. Do you have any resources to help me?
Just give up. I think, those are realities, right? So for me, I would be looking at the family first, or so there's no one involved, right? What's her living situation like?
She's living on her own. Her son is a felon who's stealing her morphine, and her ex-husband just had a stroke, so he's not helpful either.
Does she have neighbors, friends, anything like that that you know of?
No.
Yeah, it's tricky. I mean,
And no one to
honestly,
call 911.
there are situations like that. You said, so let me get this right. Deaf, mute, what else?
Illiterate.
Illiterate. Can she recognize numbers at all? 'Cause
Yes.
a big part of it, maybe she's not checking because she wouldn't be able to
She said she
interpret
doesn't
it.
like the finger pokes
Hmm?
either.
And she's taking no medications, right?
No. Her A1C and her last fasting glucose were actually surprisingly good.
Uh-huh.
But it's going to be 9 months, and they look
Mhm.
good now.
Mm-hmm. So I would say, in a case like that, I would be more concerned with, from a clinical perspective, monitoring her A1C, right? And not trying to force things that are going to be too difficult for her. But I honestly don't have a good answer for that. I think being creative, right where I go to is also asking her, right? So I don't know how you communicate with her, but is it by, how do you usually communicate? In person?
We use an American Sign Language interpreter.
Okay, and that's in person?
Yes.
So one of the things I would think about, have you done any demo testing or watching how she's testing her blood sugars?
She's not.
So, because she doesn't like to poke, right?
Right.
So one of the things that I would think about is working on that, seeing if she could bring in her meter, see what she's doing, right? There are things we can do like adjusting the depth of the lancet, right? Using warm, clean hands gets blood out a little bit easier. They don't have to poke as deeply. Where she's poking, I tend to tell people, if you put your hand on a table or something, the parts that aren't touching the table are the parts that you can poke. And so trying all around those areas tends to be helpful, and they can find a place that's less painful, but also setting realistic goals for her, right? So if she's not going to test that often, can you work on something that's like maybe test once a week? And when she tests is probably the most important part. So just testing randomly is not going to do much good, right? From a provider perspective, I think you could probably say seeing one random blood sugar doesn't do a lot for you. So if that one is at least a fasting or a before bed and a fasting, so at least we're getting some data that clues us in. And also, I would be working on, does she know why she's testing it? Most of the time we tell people, test your blood sugar 3 to 4 times a day, and we don't give them any reason why. Bring it in and let me look at it, right?
And that's, I guess, another question I have for you is, do you have any maybe pictograms or visual aids where I can kind of, I don't even know if she understands what diabetes is or
Mhm.
not, and the importance of checking your blood sugar and what that actually means.
So check the ADA website. That's a really good place for that kind of thing.
It's surprisingly limited.
It is limited, and it's also really hard to search.
Yes.
But what you could do is actually call them too and see if they know of those things. There are some things, what I'm shocked by is how little there is for assistive devices for people that have disabilities. There are some interesting things for people that are blind. There's a smartphone app now that you can scan over things and it will read to you, which I was just like blown away by when I found, but it'll even read a glucose meter. So, there's only one really good talking meter. There's a couple of them, but Prodigy is the one that we tend to use, and it kind of stinks. So it's just hard to use. So if you can find a meter that they can use, that can be an option. But I don't have a lot of good options for you, unfortunately.
Do you have contact information?
Did I not put my email address on here? I can't remember if I put it at the beginning. My email address is Vander, HJ, VANDER, HJ, at ohsu.edu. That's my email address. Yeah, so feel free, and like I said, I don't have all the answers to any of these things. The reason you're struggling is because it's a really challenging situation, but I'm happy to brainstorm. And honestly, if I could give one piece of advice, it's take it to the patient, right? Like, make sure they know why they're doing what they're doing. And that may take you actually like communicating all that in sign language, right? Asking those questions. It may be that a visual aid is not going to be useful, right? So what I would do is break that into the simplest segments, like even going into it with like, here's the 3 things that I feel like she may need to know that I don't know if she knows now, and asking her those. And then asking her, what do you want to know about your diabetes, if anything? So really letting her set that tone, I think, is going to be a more successful outcome than, okay, I'm just going to like lambast her with all this information and hope that she understands it.
Right.
Yeah.
Thank you.
Yeah, of course. Anything else? Yeah.
In your introduction, it said you're part of a protocol committee. Is there such a thing as a standing order for diabetes treatment?
It depends on the organization, right? So we don't, and delegation protocols and standing orders are like a constant struggle because even CMS doesn't define. They use standing order and delegation protocol interchangeably. There's not a really concrete definition what nurses can actually do. So legally, based on the Oregon Practice Act, nurses cannot start any medications. So I don't know if you guys are doing that with INH at this point. You probably have standing orders to do a lot of that stuff. But for insulin, for example, it's very difficult to make some of those things happen, especially when it comes to adjusting the medications. I would say there are algorithms that the ADA produces that have really concrete treatment trees.
Okay.
But in terms of like an actual standing order for diabetes management, that's the closest thing that there would be, right? Is basically looking through those. And those are really clear about starting metformin, and then they've changed a little bit now. They suggest starting a GLP-1, which is an injectable, as opposed to some of the other orals that they've taken before. But there are new data coming out on that all the time. And so that's a really good place for you to refer the PCP to as well, because you'd be surprised the stuff that I see a lot of PCPs starting people on randomly. Not you, I'm sure. Other questions? Yeah.
One of your slides in the beginning talked about transitions as a time to review health education around diabetes, and that a lot of the nurses in this room routinely face, and that's something where people have been out of care, and continued diagnosis is what gets them back in.
And that's when they find out they have diabetes as well?
It could be, or it could be that it's been, just kind of something they're aware of but not managing, but now all of a sudden it's important because they're really sick.
Right.
So I'm wondering, what are some, we get like 30 minutes with the patient every couple of weeks and then maybe once a month. What are some like pretty good recommendations for like the pearls that we should espouse? And
I think the general thing is knowing what diabetes is, right? Knowing what high blood sugar is and why we're trying to control it. If they have an understanding of that, that gives them some basis. When I see a patient, if I had my way, then like I said, I would let them set the tone for this, but I would like every patient to know how to treat a low blood sugar. Ultimately, in terms of risk, that's probably the highest risk situation for them. But getting them to know their goal, if they're gonna test, getting them to know their goals is another really important one. So what is an actual blood sugar goal for someone with type 2 diabetes, right? And then the meal planning thing, I would say plate method, finding out what their exercise is and what they might be working towards, even if you never say anything about 30 minutes 5 times a week. Just finding out what they're doing and that exercise affects their diabetes, right? And essentially, the more of it they do, the better control they're gonna have, right? But I think because diet and exercise are difficult and we can't prescribe them, we tend to completely ignore them, right? Or we give some prescriptive, do this 5 days a week, and no real quantification of why we're doing that or what less might be okay to do with that. Does that make sense? I wish we could break down all those things and I could go through, but I would say really whatever you can do to build their understanding and honestly finding out what their worried about, right? Because more often than not, what they're probably worried about is, I'm going to lose my feet, I'm going to have a heart attack, if they even know that that connection is there. And so really identifying that those are things that are a result of uncontrolled diabetes, and also that those are all about controlling risk, right? I have patients that are so worried about all these long-term effects, and they're exactly that, long-term effects that we're trying to mitigate the risk of. You could have perfectly controlled diabetes and get hit by a bus, right? And so all of this is risk management. And I really try and call that out as that. Like, what we're trying to do is reduce risk, right? Good, great question. I think I'm about out of time.
Thank you, Eric.
Thank you guys so much.